the president of Arab Board of Radiology. Please welcome Dr. Koutubi. He's going to be talking about varicocele embolization.
Yeah, good morning. Thank you. I'm happy to see all these faces today, still at the last session, given the hard task of giving the last talk after all the excellent talks this morning, particularly the last one by Dr. Shemmari. I'm sure that many of you in the audience actually do varicocele embolization. Not sure what else I can tell you about it, but I'm going to try today to suggest to you some different approaches, perhaps to the ones that you are already using, and remind you of some of the facts about it. So, of course, varicocele, as you know, is associated with infertility. It might cause pain. And these are the indications usually for treatment of varicoceles. Recurrence is also frequently seen, or not infrequent anyhow. And the other indication we need to think of is the occurrence earlier than expected in childhood or in adolescence. And of course, the mainstay of diagnosis for varicocele, in addition to the clinical examination, is the ultrasound examination. You're looking at the size of the veins and also at reflux on Doppler. Embolization of varicocele has been in existence for quite some time, and we now have plenty of literature on comparison between surgery and embolization. And perhaps I should remind you of some of the advantages of embolization, which you can mention to your patient and discuss with your colleagues. Of course, the risk of injury to the arteries doesn't exist, and the recovery period is much shorter with embolization. And hydrocele formation, which is a very distressing side effect of surgery for many young men, also doesn't exist. So all these are strong points that you can mention to your patient and discuss, and perhaps indicate in your media advertising. Does varicocele recur after embolization? Yes, they do, and the incidence that we have is about 5 to 10%, and relates, of course, to the presence of collateral circulation, the contribution from the internal iliac circulation, and other things. By the way, recurrence also occurs in surgery, even when the surgeon is very meticulous about dissecting the veins at the internal ring. So we do have a recurrence rate of about 5 to 10%, whether you're using surgery or embolization. Access, well, traditionally in the past, of course, femoral vein was the common access for varicocele embolization, and they are specifically designed catheters for the femoral access. I think more recently, the jugular access is more commonly used, and I want today to concentrate on the brachial vein access. And this is something that I've been using since my days in England, and I think it's the easiest and probably the simplest way of approaching the ovarian testicular vein. So you're talking not only about varicoceles, but also about pelvic congestion syndrome. It's simple, and now, of course, all of us, or most of you, I'm sure, do PICC lines and do venous punctures under ultrasound. You know, this is very easy to get into the brachial vein. Embolization material, well, people use coils, STD and glue and onyx and combination therapy. Personally, I think the simplest is probably the coils. They are more controlled, easier to use, and relatively cheap, but there are many people who believe in the use of STD in this context. I think glue and onyx are probably too expensive and sometimes too dangerous. Certainly you need to worry about the issue of reflux into the pampiniform plexus with liquid material, and you want to avoid that. And in the past, people advocated pressure at the inguinal ring during injection. And also with liquid material, you need to worry about or be concerned about any reflux into the central veins. Anatomy, you all know the anatomy, and of course the testicular vein or ovarian vein on the left side join the left renal vein on the left side, and drain directly into the IVC on the right side. So here's an old slide, the only slide I could find showing femoral approach actually in my collection, because I've, as I said, we don't do that. But this is a female patient, and just to show the anatomy again, the acute angle, of course, at the right, in this case, ovarian vein junction with the IVC, which makes life difficult. And in many occasions, also the stability of the catheter on the left side. So the approach from the top end is much better, much easier. And I put it to you that if you go in from the top end, don't go from the jugular, go from the brachial. And here's a reminder of the anatomy, of course, of the veins in the arm, and a word of caution: avoid the cephalic vein, because sorry, I don't know what happened here. The problem with the cephalic vein usually is the fact that you have a valve at the junction of the cephalic and subclavian, and if you induce spasm in that valve, then this is actually very painful for the patient and very difficult for you to advance your catheter, and you get into a bit of a tears. So do avoid the cephalic and definitely go for the basilic or brachial. And you see 5 French teeth in the arm, nothing. And I think the MPA catheter shape is the best shape for this. Just like you use it in the jugular, you use it in the brachial. And here's just a reminder of the steps of access. Here you are going to the left. Your MPA catheter is in the IVC, pointing toward the left renal vein. You get your hydrophilic wire into the renal vein, and so that's very easy. It helps to take a bit of a contrast injection, preferably with the table. If you can have a table that can tips down, you help the visualization of the testicular vein, and you see where it is. It's common to have lumbar veins close to the origin of the testicular vein, so you need to know your anatomy and define where the testicular vein is, aim for it, and it's really a simple function of moving your wire, turning your wire in, and it will find its way straight into the testicular vein, and then the catheter goes in, and you need to go all the way down, ideally to place your coils all the way down to the internal ring level. Before you do that, by the way, the right side is also very easy in most cases, and you can see again the direction and the shape of the catheter does allow you to get into the testicular vein without much difficulty. You need to do a venogram to define the anatomy a bit better, to see how many veins exist, because it's very common to have duplicated veins. It's also very common to have connections with various veins in the, sorry, let me see where that light is. Retroperitoneal veins, and as you know, some people even describe connections between the testicular veins and the veins of the bowel. So again, this is an issue when you're using liquid material. So once you've defined the venous anatomy, you need to go, as I said, start your embolization as low down as possible around that level, and then take it all the way up, preferably to just below the renal vein. Again, more pictures of anatomy. Anatomy can be very complex. This is a patient with a number of veins, as you see. And to achieve reduced risk of recurrence, you need to get into these individual veins and then go all the way up so that you target or treat as many of the potential veins as possible. I mean, this is an example of all these retroperitoneal collaterals that can result in recurrence. And if you don't embolize down here, and if you don't embolize around the origin of the connection, then recurrence may be quite quick. If you have a single vein, the veins and coils are very simple to deploy, and as I said, pretty effective. And here's an example of making sure that you do place some coils at the origin of the connections. So basically, it's really very simple. I'm not telling you anything new you don't know, but I would like again to emphasize the approach that makes it easier, makes it truly an outpatient procedure. I mean, the patient comes off the table and goes home straight away. you don't have to worry about the jugular, you don't have to worry about the femoral, et cetera, et cetera. Now, what do you need? And I think Muhammad has given you a very good example on how to set a practice. Well, I work in an academic institution where it's difficult to have my own clinic, and the connection or the referral frequently dependent on urologist colleagues, and for urologists, varicocele surgery is one of the bread and butter things that they don't like to give away. So we only get difficult and recurrent cases really at where I work, but then that shouldn't stop you from being inventive and imaginative, as Muhammad has done and has proved to be very effective. And all you need to do, again, is to visit his website. I think his website is really inspirational about how to attract business. And of course, you need to have the appropriate setup. You have to, again, I emphasize the difference between having direct access to patient, as Muhammad advocates, and being dependent on referral from other people. Actually, there is a difference between the two. But you still need to collaborate with colleagues. And I think collaboration and education is important. I said web advertising. And yes, web patient information. Again, referring to Muhammad's website, it's really very nice in terms of patient education. There's plenty of material on the web that you can use to augment your practice and help patients understand what exactly you do. That's in short my contribution to the meeting in terms of practical procedures, but I want to finish off by, as Abbas said, invite you all to the meeting next year, but also invite you to submit all your scientific work to CVAR, and good luck, and thank you all for attending.